Hello and welcome to Badger Talks Live, which brings exciting happenings, resources, and talent from your UW flagship campus to the people of Wisconsin and beyond. I'm Katie Johnson, a fifth-year PhD candidate working in the Deming lab in the School of Medicine and Public Health. I'm originally from Iowa City, Iowa, and over the last several years, I've worked in the Deming lab to look at genetic alterations and how they affect patient treatment response. During the month of September, Badger Talks Live is proud to showcase the latest cancer research happening at the McArdle Laboratory for Cancer Research. I'm pleased to introduce Dr. Dustin Deming, who holds a faculty position in the Department of Oncology in the McArdle Lab. Today, he'll be sharing the new colorectal cancer treatment options being developed in his lab and ways to better identify which patients are more likely to benefit from the available therapies. Dr. Deming, better known as Dusty to his friends and colleagues, also serves as the ACI Schwen Family Associate Professor of Medicine, Hematology, Medical Oncology, and Palliative Care in the Department of Medicine. He is the director of the J.D. Fluno Colorectal Cancer Precision Medicine Program and co-leader of the Developmental Therapeutics Program at the University of Wisconsin Carbone Cancer Center. His subspecialty, clinical and research focus is in colorectal cancer and pancreatic cancers. He is an early age onset colorectal cancer survivor himself. His research aims to develop innovative treatment strategies for cancer depending on the molecular profile and tumor microenvironment characteristics of a patient's cancer. As a gastrointestinal medical oncologist, his prior laboratory research has been successfully translated into clinical trials, including NCI CTEP and industry-sponsored clinical trials. Dusty will be answering questions at the end of this presentation, but feel free to post them in the chat at any point. Please welcome Dr. Dusty Deming.
Thank you so much for that kind introduction, Katie, and thank you for all your hard work in the lab. And thank you for allowing me this opportunity to give this Badger talk today. I am very excited about some of the developments that we've made specifically in personalizing treatment strategies specifically for patients with colorectal cancer. Today, we're going to talk about first the kind of evolving understanding of colorectal cancer subtypes, the importance of identifying colorectal cancer subtypes, and then we'll move into using circulating tumor DNA to detect minimal residual disease for colorectal cancer patients, and then also end with the studies that we're doing in our lab specifically related to patient-derived cancer organoids. When we've been thinking about treating patients with colorectal cancer for the last 30 years, we've unfortunately not known better and have just been treating patients based on their stage of disease. So for example, patients who present with metastatic colon cancer, so colon cancer that spread to other parts of their body, what we would do in clinic was typically start with one chemotherapy recipe, and then when that one didn't work anymore, move on to the next one, and then when that one didn't work anymore, move on to the next one, etc. What we've been seeing, though, is that there are a lot of features that we need to take into consideration when we're developing treatment strategies specifically for patients with colon cancer. These include patient features, clinical features, and also now molecular features of the cancers. When we're thinking about patient features, it's important for us to understand kind of how up and active the patients are, what other medical problems they have, what symptoms they're having related to their cancer, and also what are the specific goals of care for that individual patient, as some patients would like to be more aggressive than others in their treatments. It's also important to understand specific clinical features of the cancer. We're now learning that it matters where in the colon the cancer forms. So if it starts on the right side of the colon versus on the left side of the colon, that makes a big difference in how we actually treat those patients. It's also important for us to understand kind of how much cancer is there. Patients with bulkier cancers, so kind of just more cancer in general, need more aggressive therapies than patients who have a limited amount of disease. And what we're also seeing is that patients with colorectal cancer that's only spread to one or two or maybe three spots, what we call oligometastatic cancer. If we can resect those spots, we still can offer those patients a shot at cure, which is really exciting. And there's now this new area of understanding in colorectal cancer that we call minimal residual disease. This is where we can use biologic markers, usually a form of a blood test, where we can detect the cancer using the blood test, but can't actually see it on any of our CT scans or MRIs or other imaging tests. This is a really unique situation now that is a result of us having a greater understanding of these cancers and a new area of very active research. In addition, we now understand that these cancers can have many different genetic changes that kind of make the cancer cell become a cancer cell. These include mutations in genes such as KRAS, NRAS, BRAF. We can also see cancers having what we call mismatch repair deficiency, where they have trouble fixing the DNA of the cancer cells. So those specific cancers acquire hundreds, if not thousands, of different changes in their DNA or mutations. And these hundreds or thousands of mutations actually lead the cancers to be looking very abnormal to the immune system. And I'll show data in a little bit about how we can now use new therapies that help harness the immune system to better treat cancer, can be really effective for these patients. So overall, we are now understanding colorectal cancer is not just one disease. And there are many different subtypes of colorectal cancer. And based on the mismatch repair status, how many mutations we see in the cancer and what specific mutations are there, we're now better understanding the treatments for these patients. So every one of these boxes that you're seeing on the slide is a different subtype of colorectal cancer. And each of these subtypes now has very specific treatments. And so no longer are we just moving from one chemo regimen to the next, to the next, to the next, but we're actually doing this in a much more educated fashion, where we're able to actually understand the biology of individual patients' cancers and tailor these treatment strategies to their specific cancer type that they have. Here's an example for those patients who have that mismatch repair deficiency that I was talking about, where patients with metastatic cancer that's spread to, in general, many sites of the body. Typically, we would think of these cancers as not being curable and historically have just been treating these patients with chemotherapy. What we see is if we use some of the new immune therapies, what we call anti-PD-1 therapies that help prevent the cancer from turning off the immune system, these new therapies can actually provide cure for some patients despite the cancers being spread. So as you can see here, it's about 40% of patients in this study that had a drug called pembrolizumab that 3 years out had no progression of their cancer on this therapy. Whereas with chemotherapy, almost all of the patients had their cancer grow at that point. We now have combinations of immune therapies which look even more promising moving forward. Here's an example of a patient who we used immune therapy for their mismatch repair deficient rectal cancer. And what you can see here on the CT scan is that this area here is the rectum, and all of this white tissue that we're seeing in the middle here is their cancer. This patient had the mismatch repair deficiency and was treated initially with standard of care chemotherapy. And unfortunately, their cancer continued to grow despite that chemotherapy. And it actually even started to move forward and invade into the bladder. The patient was then switched to immune therapy. And what we see is just within a few months of starting that immune therapy, the patient has had a complete response. The patient ended up having some narrowing of the rectum and ended up having this part of the rectum surgically removed, and there was no evidence of any cancer remaining on pathology. And that patient is doing very well without any evidence of cancer now years later. One of the major goals of our cancer center is to not just be a cancer center in Dane County, but also a cancer center for the entire state. And when we're thinking about now trying to personalize our treatment strategies based on the mutations or the changes in the DNA of each individual patient's cancer, this gets really complex really fast. And our cancer center director, Howard Bailey, wanted to make sure that no matter where you lived in the state, you had an opportunity to have the expertise that we have here at the Carbone Cancer Center reviewing your case. And so we developed our Precision Medicine Molecular Tumor Board, which is a group of oncologists, geneticists, molecular pathologists, surgical pathologists, pharmacists, kind of all of the specialties that are required to understand the genetic changes in a patient's cancer and develop drug regimens specifically for those patients are involved. And this is a free service now where any patient throughout the state, their treating physician can submit any genetic testing that they have to our tumor board, and we can review that patient's case, the genetic changes in that patient's cancer, excuse me, and we can that patient's cancer, and we can also provide recommendations back to that treating physician. We can talk to them about what clinical trials might be available, what standard of care therapies might be available, but additionally, what FDA approved therapies that are out there that we may not have otherwise thought of for that patient, but because of the genetic changes in that patient's cancer, we can now recommend these new therapies for those patients. We've had a lot of success with this tumor board so far. We've provided expert analysis on over 70,000 patients to date across 16 health systems throughout the state. Patients in 94% of the 2,000 recommendations for clinical trials. And excitingly, this tumor board is now partially funded through the Wisconsin state budget to make sure that we are offering this analysis to as many patients as we can across the state. One example of a patient who was presented at our tumor board is a patient who came to us from Marshfield. This is an 81-year-old gentleman who had a new diagnosis of colorectal cancer. The patient previously had a head and neck cancer and had a really hard time with chemotherapy and radiation. And at 81, he was thinking that he didn't want to have any more therapies. We did molecular profiling of his cancer and found out that his cancer was much different than the vast majority of colorectal cancer patients. And in fact, his cancer from a genetic standpoint actually looked more like a breast cancer. And so we treated his cancer with a very well-tolerated drug. It's an antibody and not a true chemotherapy. And he had almost no symptoms from this therapy, but had a remarkable response and did extremely well with this treatment strategy. And had it not been for our tumor board and the analysis that we did, this patient would have never known that this was a possibility for them. So now let's move on to using circulating tumor DNA to help us identify patients who are at risk of their cancer coming back, because we can detect their DNA from their cancer in the bloodstream. So this is a new technology where patients, first, their cancer is sequenced, meaning we look for what makes their cancer cell different from the rest of the DNA in their body. And then we pick specifically 16 changes. This is in collaboration with a company called Natera. They pick specifically 16 alterations that they think that are different in the cancer than in the patient's normal DNA. And then look for those specific genetic changes in the patient's blood over time. And what has been demonstrated previously in studies is that after surgery, if the patient's blood test can detect DNA from the tumor, that means that there are still cancer cells around. And so many, if not nearly all of those patients, if they're not given adjuvant, meaning after surgery chemotherapy, their cancers will come back. If the test is negative, it's not perfect. It doesn't mean that their cancer won't come back, but the odds of their cancer coming back are markedly different. So as you can see here, those patients who were ctDNA negative at 3 years, 75% of those patients did not have any recurrence of their cancer. Now, this is compared to those patients who were ctDNA positive, where 75% of those patients had their cancer come back. We've now used this test on over 100 patients and have been following them closely, and combining our data with data from other groups across the world. What we are seeing is that specifically for colorectal cancer patients who have the cancer spread to lymph nodes, what we call stage 3 colon cancer, this is where we're most commonly using chemotherapy currently for patients in clinic. If after surgery, their DNA test from the bloodstream is positive, that happens in about 20% of patients. If we give those patients chemotherapy, our standard chemotherapy, a regimen called FOLFOX, 40% of those patients don't respond to that chemotherapy and their cancer comes back anyway. 60% of patients, we can see that DNA clear from the bloodstream. However, of those that the DNA clears, unfortunately, 2/3 of those patients with our standard therapy still have their cancer come back. And it's only 20% or so of patients that are actually cured because of the chemotherapy in this setting. This leads us to want to think about, should we do more or try to identify a better type of chemotherapy to give this particular patient population that's at extremely high risk because their DNA is detected after surgery, and the tumor DNA is detected after surgery in the bloodstream. 80% of patients after surgery in our data set show that they are negative for the tumor DNA in the bloodstream. And we currently would still give those patients chemotherapy. Now, what we see is that 70% of those patients don't need that chemotherapy at all, meaning that they were cured by surgery alone, and the chemotherapy that we give them now as standard of care wasn't needed at all, but we don't know how to detect who's who. 30% of patients would have had their cancer come back if we hadn't given the chemotherapy. Of those that we do give the chemotherapy, it's 67% or 2/3 of those patients who we then cure because of the chemotherapy. So overall, 20% of the patients who are initially ctDNA negative are the ones who really benefit from us giving chemotherapy in this setting. And unfortunately, of the overall population, there's 10% of patients that, even despite us giving our current standard chemotherapy in this setting, those patients have their cancer come back. So this leads us to a couple really exciting clinical trials. And these are national clinical trials that I am part of the study team. The first is a study called the COBRA Study. And this is really looking at, should we be doing this circulating tumor DNA analysis for all patients with stage 2 cancer? So the patients are randomized, one, to patients getting kind of standard of care, which for patients with stage 2 colon cancer, the typical standard of care is just to watch and see if the cancer comes back. We typically don't give chemotherapy for these patients because the cancer hasn't spread to the lymph nodes yet. So their risk of the cancer coming back after surgery is pretty low. However, we know that there's still about 10% of patients that the cancer could come back. And we're hoping that by doing the circulating tumor DNA assay, we can actually identify those patients and then give those patients chemotherapy. So in the experimental arm here, the patients get therapy based on their ctDNA test. So those patients who have ctDNA detected after surgery would then go on to get chemotherapy to see if we can clear that DNA and prevent their cancer from recurring. Whereas those patients after surgery who are negative, we continue to watch very closely, but don't treat with chemotherapy. Excuse me. Additionally, the Circulate US study is another study that I'm part of the leadership team on. This is a national study through our National Cancer Institute. This study is looking mostly at patients with stage 3 colon cancer and looking at, for those patients who we detect DNA in the bloodstream after their surgery, should we continue to do the typical chemotherapy that we do now, which is a regimen called FOLFOX, or should we add another drug to that regimen, a regimen that we call FOLFOXIRI, which is a 4-drug regimen versus a 3-drug regimen, thinking that maybe for this really high-risk population, we should try to escalate our chemotherapy to have a better shot of curing those patients. Additionally, those patients in this study whose DNA test is negative, they're being randomized to our typical standard of care, which would still be the FOLFOX chemotherapy, versus an alternate approach where we are watching those patients over time. And only when their DNA is detected would we then consider those patients for chemotherapy. So these are two really exciting ongoing clinical trials that are available to our patients here at the Carbone Cancer Center and also nationally. Lastly, let's move on to the promise of patient-derived cancer organoids. So one of the major issues with trying to develop personalized or individualized treatment strategies for patients with cancer is that what we really want to do is actually be able to test, do these drugs work for an individual patient in the lab? And one of the problems is that it's only about 10% of patients' cancers will grow in the lab. Mostly what we're have been trying to do for the last 60 plus years is get patients' cancer cells to hook onto a plastic dish, or what we call a petri dish, and see if the cancers will grow that way. But most cancers, especially colon cancers, don't like to hook onto plastic, and that makes studying these cancers very difficult. In addition, those cancers that do hook onto the plastic, that changes how the cancers behave, and they behave in a way that's much different than the way they behave when those cancer cells are in the patient. And so we're hoping that this organoid approach that I'll be discussing is a better strategy for growing patients' cancers. So I don't know about you, but my family still has a lot of Jello molds for all of the holidays, and this is somewhat of an inspiration for the technique that we're using here. So instead of having to require the cancer cells to lock onto the plastic at the bottom of a dish, we actually lock the cancer in a substance called Matrigel, which for all intents and purposes, you can kind of think of like a form of Jello. in that it locks the cancer there, but the cancer is still able to grow. It's still able to move, but it no longer is required to hook onto the plastic. And so what we see in the picture here on the right are these little structures that the cancer cells form. And these little structures are reminiscent of the architecture of how cancers grow in patients when we look under the microscope at sections of patients' cancers. And so we've been doing a lot of studies to see, can we grow these organoids from patients' cancers, and can we use them to actually predict how patients are going to do in the clinic? We've now grown over 300 patient samples and done numerous treatment studies and also genetic analyses on the patient's organoids. So what we're doing is actually taking either a biopsy through a colonoscopy scope, or getting a surgery specimen from a patient. We break down the tumor using some enzymes to free up the cells. We wash those cells, and to be frankly honest with you, it's really amazing to me that we can grow anything out of a patient's intestine without the culture getting infected. But our washing and antibiotics that we use to help clean these samples are very effective. We then place the cancer cells into a droplet of the jello-like substance called Matrigel. And then we put nutrients in culture media or fluid over the top of that droplet. And this has been very successful. We are now able to grow 80 to 85% of patients' cancers using this technique, which is really a game changer for us, being able to have that many patient samples in the lab. And excitingly, what we're seeing is that those organoids that are grown in this way much more represent the way cancers grow in patients. We can see a lot of heterogeneity and kind of differences in how the organoids grow, even in the same patient sample. So what we know for some patients in clinic is that different parts of their cancer will respond better to different treatments. And this organoid technique, it allows us to look at each individual part of the patient's cancer that we're growing and see how the whole population of these organoids is either growing or responding to therapies. And so what you can see here in these pictures is this was the first picture after we established the culture. And then 2 days later, you can see these organoids growing and individual organoids growing at different rates. So we, when we're assessing the response to drugs, we look at each individual organoid over time, and we actually measure across the organoid to get changes in size. And we also work with Melissa Scala, who is a biomedical engineer, to look at the individual metabolism of these organoids over time as well. Here's some examples of patient organoids and how those patients actually did in clinic. The first patient was a patient with breast cancer who was going to be treated with a drug called gemcitabine. We treated the patient's organoids with the same chemotherapy that they were getting in clinic. And what we saw is, despite the same dose that the patient's getting in clinic, their organoids did not change in size, meaning we didn't see any shrinking of their organoids. And what we saw in the patient in the clinic is, unfortunately, this particular type of chemotherapy didn't work for this patient. The white line here is measuring a lymph node towards the back of the patient that had cancer in it that grew over time here on these CT scan images. In a patient with metastatic colon cancer that had spread to the liver, we were able to grow their organoids and treat them with one of the standard chemotherapy regimens that we typically use first for most patients, a regimen called FOLFOX. And what we saw is that in this case, the patient's cancer either stopped growing or in many cases became really dark and shrunken, which is a measure of the cancer's, the organoids actually responding to the chemotherapy. So the darkening happens because of dead cells kind of being sloughed into the center of the organoids. And this treatment response that we saw in the clinic also predicted response for this individual patient. So this is here the patient's liver, and this is a big spot of cancer that the patient had on the liver. And what we saw after just a few months of chemotherapy is that this large mass had responded quite dramatically for this patient. We've now looked at the actual response from the organoids and compared that to the response in patients for about 30 patients so far. And what we see is kind of interesting. So for those patients who their cancer shrinks quite dramatically, that's the red side over here. What we see is that if they shrink very dramatically, that means the patient's going to respond to that chemotherapy 100% of the time. If we see that the cancers don't grow, that's this tall gray bar over here. I'm sorry, the cancers don't respond at all, that's this tall gray bar over here, then there's 100% chance that, 100% of the time, those patients are not going to respond to their chemotherapy. And if we get an intermediate response in the organoids, it's about a 50-50 chance whether or not those patients will benefit from that chemotherapy. And so we're really excited about continuing to move this work forward and have funding from the NCI to continue moving these studies. Additionally, we had a patient who came to us from the Milwaukee area, and their cancer had been resistant to all known therapies. We grew organoids from that patient and tested multiple different chemotherapy regimens. And what we saw was that this patient's cancer actually became, or their organoids were sensitive to the first chemotherapy regimen, again, that the patient had 4 years ago. This patient was then treated with this particular regimen and did extremely well, had a great response. You can see the cancer spot here in the patient's liver had shrunk, and you can see these little white spots that formed in the patient's tumor. That's actually calcifications because of all the cells dying there. So we're really excited about, in the future, moving this technique into clinical trials where we can actually decide what therapies to give a patient based on screening for drugs using these organoid techniques. So in summary, I hope what you've seen is that the more we know about a patient's cancer, the better we can develop treatment options for them. It is now standard of care to do a lot of the molecular testing that we are doing, both here, but also in the community throughout Wisconsin. I'm very excited about our molecular tumor board and the ability to provide a lot of the resources that we have here at the UW for patients who are getting seen throughout the state, especially in rural communities. Additionally, we're very excited about ctDNA and these organoid cultures as being new tools that will hold great promise for not only identifying which patients need therapies, but also for developing new therapies and identifying what drugs might be the best drugs for patients. So thank you for listening to the talk today. I appreciate the invitation to give the talk. Thank you to my laboratory, our collaborators, and all of our funding resources. And additionally, I'd just like to say a big thank you to all the patients who participate in our studies. Obviously, I hope that our studies are helping them individually, but they're also helping move the field and helping us develop better treatment strategies for patients in the future as well.
Wow, that's really impressive work. Thank you so much for sharing that with us today, Dusty. Hello, everybody. Fran Paleo-Moyer, Badger Talks producer. So a couple of questions for you. And everybody, please feel free to post questions in the chat if you have them. I do see actually something posted here from B Hot. So for current colorectal cancer patients working with the UW Carbone Cancer Center, are they looking at the ctDNA in the blood to determine treatment options? I'm undergoing treatment with FOLFOX. I'm not going to be able to say this word, BEVACIZUMAB.
Yep. So currently where we're seeing the potential benefit for patients with circulating tumor DNA is in patients who have had surgery and now we don't see any evidence of cancer on their CT scans. So in that setting, we are offering to do the circulating tumor DNA test. For patients who are undergoing chemotherapy for cancer that we can see on CAT scans, we don't yet know what the benefit of doing that ctDNA testing would be. And so we're not routinely recommending that type of testing now.
So this information that you've developed, that's available to basically everybody in Wisconsin. How is that information shared with other doctors and other hospitals?
So great question. So we have a every other week molecular tumor board that is a virtual tumor board where basically it's open to the public. Anybody could come watch our discussions. It's all being done in a way where we don't release kind of any of the protected patient information. Many oncologists throughout the state join to talk about their individual patient cases. After that meeting, we talk about the recommendations, and we have a guidance document that tells us kind of the types of recommendations that we should give, and also put some boundaries and some rules around the type of recommendations that we shouldn't be giving for these patients, just to make sure we have our checks and balances, because sometimes when we're talking about cancer patients, it's easy to get emotional and want to try to do things that maybe don't make sense yet, or the data is not there yet for. So we do have some kind of boundaries on that. But then the patient's physician gets a letter from either myself or Dr. Burkhardt, who's an oncologist that I work with, outlining what we found based on the patient's genetic report from their cancer and what potential treatment options that may lead us to recommend. Which again could be clinical trials, it could be standard of care therapy, or it could be kind of off-label use of therapies.
Wow, that's very specialized. Great work that you all are doing. Thank you. So how does it work with in some of the talks and in various topics, right? Some not necessarily medicine, other topics. We've talked with faculty who are in research working with labs in other states, in other countries. Is there work being done outside of your lab in collaboration with any other labs?
So absolutely. There are many different labs specifically looking at the organoid work and also circulating tumor DNA. We work in parallel, but also in collaboration with them as well. Basically combining our experience with other groups' experiences to help move the field forward.
Great. And Dusty, I know you're a cancer survivor. Can you tell us a little bit about how that maybe has changed the work for you or better informed your work?
Yeah, so when I was finishing up my oncology training, I was actually 2 weeks into a faculty position here at the UW when I myself was diagnosed with colorectal cancer. And that was over 10 years ago now. Been through surgeries, chemotherapies, radiation, all those things. And boy, I learned a lot from that experience. And when I first started as a physician, to be frankly honest with you, I didn't get it the way I get it now. I didn't understand what all of this meant to the patient who was hearing the cancer word. It really has helped me sit down with patients and be able to say, I've been there. I don't know how it feels for you, but I can tell you how it felt for me, and I can tell you how I got through that experience. And I hopefully learned a few tricks along the way to help make your experience better as well. Or another example of this is, I had a patient who was really nervous about the surgery that he was being offered, and I could say to him, I've been there. I've had that exact same surgery, and I can tell you, in what ways that surgery will change your life. But I can still tell you that there's life after that surgery,
Yeah.
which really helped that patient go on to have a life-saving surgery that I'm not sure they would have otherwise been willing to have.
Right.
I don't wish a cancer diagnosis on anybody, but having been through it at age 31 has given me a lot of opportunity to share my experience with others. And from a research standpoint, it's really pushed the urgency of our work. As you can see from my presentation, and this is only a small bit of what we're doing. We're trying to do a lot. We're trying to do a lot at a time, and we're trying to move things as far and fast as we can. And I think a lot of that comes from my personal experience and realizing that patients need these options, and they need these options now.
Thanks so much for sharing that. That is really we appreciate the gifts you're sharing. Thank you so much for that. I can't imagine as a patient having a doctor that can empathize in that way, how much more support that brings to the person. So thank you for that. Well, last question is, what's a colon cancer diagnosis going to mean in, say, 20 years, do you think? Or when is there a point where you think this will not become such a devastating, potentially, diagnosis?
So I think what is really going to push the envelope for colorectal cancer is still screening. If we catch colon cancer early, no matter how you do it, whether it's with Cologuard or with CT scans or with colonoscopies or stool blood tests, whatever it takes, catching it early, there's just so much that we can do. Unfortunately for me at 31, we didn't know to screen at that point. And what we're seeing is that colon cancers and rectal cancers especially are being found at earlier and earlier ages. And so this has pushed the American Cancer Society and sorry, my lights just shut off. And other, apparently I haven't moved enough today. And other groups to recommend colon cancer screening now at age 45. And what I see is that moving earlier and earlier. And as we're getting more tests that actually are non-invasive and have less risks, I think the earlier that we are going to be screening patients and the more often we're going to be screening patients is going to make the biggest difference in patients. Now, I'm also excited about the new technologies and better ways of personalizing therapy. So if patients do get cancer and need it treated, I do think we're going to have better treatment options. Right now the field's moving so fast that, excuse me, every 6 months or so, I'm getting a new drug to fight colon cancer.
Wow. That's impressive. All right. Well, thank you so much for your great work, for your lab's work. Just know we're all touched by this in some way, and we appreciate it. You're the superheroes of the research world here for us. So thank you. So we'll continue showcasing important work coming out of the McCardle Lab for Cancer Research. We'll continue next Tuesday, September 20th at noon. We're going to be talking with Dr. Bill Sugden, who's the James A. Miller Professor of Oncology and the American Cancer Society Research Professor. And he's going to be talking about viruses and how they relate to cancer, and specifically two viruses that cause one cancer. Please check out our website at badgertalks.wisc.edu, where you can see the upcoming schedule of talks. Check out our podcast with host Ben Rush, where he interviews select Badger Talks Live presenters. Sign up for our email list to be the first to know about upcoming talks. And then also search the roster of over 400 UW faculty and staff who've generously donated their time to give talks in communities like yours around the state about issues that are important to you. Thanks for tuning in, and we'll see you next Tuesday.